So, now we will talk about STDs, sexually transmitted diseases. We have common sexually transmitted diseases are bacterial or viral. The bacterial ones are chlamydia, gonorrhea, syphilis, and trichomoniasis, and the viral ones are HPV, HSV2 or HSV1, and HBV. Chlamydia. The epidemiology. It's the most common reportable disease in the US. Most infections are asymptomatic, and it's the leading cause of infertility in women, and much more frequent in women than men. Which are the manifestations? Well, in females, it's 70-80% asymptomatic. In the genitals, we can have cervicitis, pelvic inflammatory disease, and urethritis. In the eye, we can have conjunctivitis, in the throat, pharyngitis, and in the rectum, prostatitis. In the males, it's more than 50% asymptomatic, so a bit less than in females. In the genitals, we can have urethritis and epididymitis. In the rectum, proctitis. In the throat, pharyngitis. In the eye, conjunctivitis. And if systemic, we can have Reiter's syndrome, which is a form of reactive arthritis. In the neonates, we can have vertical transmission. In fact, we can have vertical transmission, so we can have conjunctivitis in the eyes and pneumonia in the lungs. So prophylaxis of pregnancy women is done. So an untreated genital chlamydia trachomatis infection can evolve in 20-50% of cases in pelvic inflammatory disease, acute or silent. And this is the main cause of infertility, actually, pelvic inflammatory disease. 9% of cases have ectopic pregnancy due to fibrotic obstruction of tubes. 18% have chronic pelvic pain due to fibrotic adhesion in genital organs, and 20% develop infertility due to bilateral tubal obstruction, in this case of pelvic inflammatory disease. Diagnosis is not clinical, and in fact, clinical findings are not so clear. Recommendations for screening. All sexually active women less than 26 years old, we should have an initial screen, repeated annually, consider repeat with new or multiple sex partners, and repeat 2-3 months after an infection. All pregnant women under 26 years, men and women aged 26 and older, consider with new or multiple sex partners, inconsistent condom use. The urine-based chlamydia test is a non-invasive and a highly accurate test, urine-based. Partner management. So, how can we treat the partner? What can you say about the partner? Well, we can say that in terms of transmissibility, we have a male to female transmissibility of 20, 45, 55%, in culture to 70% PCR. Female to male is 28, 42% in culture and 68 PCR. Partners with contact during the 60 days preceding the diagnosis should be evaluated, tested, and treated. Patient-delivered partner therapy can be done. Patient-delivered partner therapy can be done. Screening men for chlamydia is advised since they are the obvious source of infection. Urine-based testing are available, still no demonstration of the not demonstrated actual effectiveness still no actual effectiveness has been demonstrated, and no guidelines are thus available. Treatment is done with a single dose of azithromycin, which reduces by 30% the risk of getting in the risk group. So, key points are most common bacterial chlamydia, most common bacterial curable STDs in the US, most cases in women and men give no symptoms. Leading cause of pelvic inflammatory disease and infertility in women, and all sexually active women aged 25 years and younger should be tested at least annually. Gonorrhea, caused by Neisseria gonorrhoeae, epidemiology, much less important than chlamydia. Overall, the rates are not falling, but the incidence in certain groups remains high. It's most common in young adults and adolescents. Resistance to medication is a spreading problem. Prevalence among men and women and in different subgroups is quite similar. Which are the manifestations? Men are more symptomatic than women, who are commonly asymptomatic. In men, we can have urethral infection and epididymitis. It usually causes pain with urination and heavy, thick venile discharge. Few may be asymptomatic carriers. In women, we can have cervical infection and pelvic inflammatory disease. About 50% of women are asymptomatic, others have pain with urination, vaginal discharge or bleeding. Other sites of infection are throat, rectum, and eye. In the neonates we can have eye and skin infections. Can we manage the partner? Well, transmissibility is high in both ways. Male to female is in the order of 50-90%. Female to male is a bit less, 20-80%. Partners with contact during the 60 days preceding the diagnosis should be evaluated, tested, and treated, as in chlamydia infection. If there were no sex partners in the previous 60 days, treat the most recent partner. Drug resistance is increasing in the last years. We can have resistance to ciprofloxacin, which is bad since it's also the first choice drug in case of chlamydia infection. Screening is not warranted when gonorrhea infection prevalence is lower than 1%. High-risk population groups must be identified and screening should be done in these populations. You should screen populations with prevalence of 1-2% or more. Men who have sex with men and high-risk women, young age, new or multiple partners, or pregnant women. So key points: gonorrhea is the second most common bacterial curable STD in the US. Concentration of infection in men who have sex with men in urban areas is particularly relevant. Resistance to medications is a spreading problem. Syphilis. Epidemiology. In the 90s, a significant peak of infections was diagnosed, and that was mainly because the criteria for diagnosis of infection changed in this period. Manifestations: secondary syphilis can be identified in many locations, like CNS, eye, ear, visceral organs, and kidneys. Primary syphiloma in the external genitalia. Therapy is done with penicillin G, IV, which is the first line of therapy, and it's actually uncomfortable since it's painful in the injection site. You can have azithromycin, which is an active second choice treatment, and second generation cephalosporin, like ceftriaxone, can be safely used. So, key points: outbreaks in men who have sex with men in urban areas since 2000. Serious systemic infection can happen. Strong connection with HIV transmission. Yearly co-testing of all HIV positive patients is recommended due to common co-infection. Genital herpes. Epidemiology: very frequent in the US, very rare in our realities like Mediterranean Europe. Not clear why. Probably it can be due to underdiagnosis in our countries. In US, 22% of adults are infected. transmission is done mainly sexually, horizontal transmission, or mother to newborn, vertical transmission. And very few patients know the symptoms of herpes, and many mistake herpes infection for something else. This may be why so few diagnoses are done here in Mediterranean countries, because patients do not even search for medical help. So the main symptoms are: in women we can have yeast infection, vaginitis, UTI, menstrual complaint, hemorrhoids, allergies, rash from sex, shaving, bike seat. In men we can have folliculitis, normal itch, zipper burns, hemorrhoids, allergic to condoms, irritation from tight jeans, sex, bike seat, insect bite. Anyway, HSV shedding happens not only in acute phases of infection, but also in asymptomatic phases of infection. It may occur from cervix, vulva, urethra, rectum, and penis. Neonatal infections are clinically relevant. You can have them in the skin, eye, or mucous membrane. No mortality, but recurrences are possible. In the CNS, we have a 30% mortality and 50% serious sequelae. You can have a disseminated, so having 80% mortality, 10% serious sequelae. Overall mortality is 20%. This transmission occurs at time of delivery, rarely in utero. The risk factors are primary infection, new infection, and scalp electrodes. Over an half of infants with neonatal infection are born to mothers with no history of genital herpes. In case of HSV infection in pregnancy, we have to do abdominal delivery. C-section is recommended when prodrome happens at onset of labor. Specific therapies can be proposed in order to avoid C-section due to acute HSV clinical manifestation and in case of recurrent herpes episodes. Give antiviral therapy starting from 34th, 35th week of gestation till delivery with no risk for the baby. Screening and recommendations for routine HSV screening is done unless for high-risk patients. So patients with or sexually transmitted disease, HIV infected persons, and contacts with HSV, certain prenatal patients. So in these cases we do screening. It's common condom protection is highly effective for HIV, but not highly effective for gonococcal, chlamydia, trichomonas, herpes, HPV, syphilis infections, and chancroid. This is because the infectious areas are not all safely covered by the condom itself. So, key points. About 1/5 of adult Americans have HSV2. Most do not recognize or get symptoms. New type-specific blood tests can accurately diagnose HSV2 infection even when no symptoms are present. Treatment to control symptoms and lessen the chance of transmission are available. Human papillomavirus, linked to cervical cancer. Benign warts are HSPV 6 and 11 related. Preneoplastic lesions and neoplastic lesions are given by high-risk types. Anal cancer is related particularly to sexual behaviors of certain group of people, such as men who have sex with men. So it is an extremely common virus. Some types cause genital warts, other types cause cervical and anal cancer. HPV tests can help in managing female patients with abnormal pap tests. Best approach to anal dysplasias is unclear. Trichomonas, caused by Trichomonas vaginalis, flagellated anaerobic protozoa. In women, cause malodorous yellow-gray discharge with irritation and vulvar itching. In men, it usually gives no symptoms, but can cause urethritis. Resistance to common treatment, metronidazole, does occur.